Hello, everyone. My name is Danielle Cunningham, and I'm the trainer that is going to be leading you through our Parkinson's disease training. So, first, we want to start off with the objectives of this training, and they are to recognize symptoms of Parkinson's disease, learn Parkinson's disease progression, understand how Parkinson's disease affects usually bodily functions, and identify non-motor symptoms of Parkinson's disease. So we want to start off with a little Parkinson's trivia. So this person is a heavy metal singer, had one of the first celebrity reality TV shows, and once bit a head of a bat off at his concert. Who may that be? Ozzy Osbourne. Now, Ozzy Osbourne was diagnosed in 2003 with Parkinson's disease, but he and his family publicly disclosed it in January of 2020. He described it as a form of Parkinson's called Parkin2, which is a rare genetic form. He kept the diagnosis private for years while managing other health conditions. Ozzy's form of Parkinson's is Parkin, which is a mutation base, which is typically a slower progressing and can have earlier onset. Despite his condition, he continued to record music, release albums, and make public appearances. He's been very candid about his Parkinson's and chronic pain, which have affected his mental health, which includes periods of depression. Due to this, he has had to cancel or postpone many of his tours. Our second person, he is considered to be the greatest heavyweight boxer in sports history, coined the famous quote, "Float like a butterfly, sting like a bee." And who may that be? Muhammad Ali. So Muhammad Ali was a legendary heavyweight boxing champion who was diagnosed with having Parkinson's disease 3 years after return from boxing. His diagnosis brought awareness and attention to Parkinson's with public appearances like the Olympics in 1996. Now, while this exact cause of his Parkinson's is not really known, some experts suggest that it is a link to his boxing career due to the repetitive head trauma that he experienced. And so despite the diagnosis, Ali became a prominent advocate for Parkinson's awareness and research, even leading to the name of Muhammad Ali Parkinson Center at the Barrow Neurological Institute. And then our last one here is that she is one of the most famous for her role on Golden Girls as Dorothy, aka Miss Sophia, and say who that may be, which is Miss Estelle Getty. Now, Miss Estelle Getty was best known for her role as Sophia in Golden Girls, which she was Dorothy's mother, but she was diagnosed with Parkinson later on in her life. In addition to Parkinson, she also battled Lewy body dementia, which often can be misdiagnosed or overlap with symptoms of both Alzheimer's and Parkinson's. Her health struggles in her later years significantly impacted her ability to make public appearances and participate in reunions that the shows may have. With these conditions and how it has affected her memory, communication, mobility, and eventually forcing her to step away from the public eye. Her struggle highlighting the challenges many individuals face with neurodegenerative diseases and helped bring greater awareness to these conditions. And so just some little trivia here. So now we're going to go into explaining what Parkinson's disease is. Now, Parkinson's disease is a long-term, gradually progressive neurodegenerative disorder that mainly affects the way a resident moves, but can also influence mood, sleep, thinking, and other body functions. Now, it occurs when the nerve cell and part of the brain called the substantia nigra becomes damaged or die, leading to a shortage of dopamine. Now, dopamine is a chemical that helps control smooth and coordinate muscle movements. Now, in our next clip, we're going to watch a video that's going to help us understand Parkinson's disease better and go a little bit more into detail explaining how the substantia nigra becomes damaged.
Parkinson's is the second most common neurodegenerative disease after Alzheimer's. The most visible features of this disease are a slowness of movement, muscle rigidity, and tremors at rest. There are also many, often debilitating non-motor symptoms, some of which may present before the motor problems. Parkinson's affects many areas of the nervous system and different types of neurons. However, much focus has been placed on neurons in brain regions associated with the overt motor symptoms, notably a region of the midbrain called the substantia nigra pars compacta. This region forms part of a major pathway in the brain that's critical for facilitating movement. In Parkinson's, dopaminergic neurons in the substantia nigra gradually die, leading to the malfunction of this pathway and the characteristic motor problems. Drugs that replace or mimic dopamine are often used to treat these motor deficits, but they grow less effective over time. Deep brain stimulation may also be used to treat symptoms. However, no current treatment slows the neurodegeneration. A distinctive pathology in most cases of Parkinson's is clumps of misfolded proteins within neurons. Lewy bodies are the most common type. A characteristic component of these is a misfolded protein called alpha-synuclein. These molecules can form small repeated units called oligomers, or longer fibrils. Mounting evidence indicates that these are toxic to neurons and play a key role in driving Parkinson's. Unwanted proteins are normally cleared by the cell's different types of protein-degrading machinery. Some evidence points to these systems being overwhelmed by misfolded alpha-synuclein, and this might be a key factor in what kills the neurons. Parkinson's has also been linked to problems with mitochondria. Mitochondria provide cells with the energy to perform vital functions. They're highly dynamic and can fuse together or break up into smaller versions in response to a cell's energy demands. They can also be transported to areas of a cell that need them the most. However, in Parkinson's, these processes can be impaired, and mitochondria are unable to sustain proper neuronal function. As they become old or damaged, mitochondria are removed and replaced. Again, this recycling is thought to be disrupted in Parkinson's, leading to the accumulation of damaged or worn-out mitochondria. Another idea is that the cells called glia surrounding neurons may play a role in Parkinson's. As dopamine neurons are lost, one particular type of glial cell, called microglia, is thought to take up the resulting cellular debris, triggering an immune response. Once activated, they release inflammatory cytokines, which activate neighboring microglia and another type of glial cell called astrocytes. Chemicals released by activated microglia and astrocytes have been shown to injure neurons. It remains unclear which mechanisms drive the disease process in Parkinson's. What is clear is that with time, more areas of the nervous system develop pathology. And one emerging idea is that this happens through the transmission of misfolded alpha-synuclein. While the multifactorial nature of Parkinson's disease progression might make it hard to fully understand, it does provide a number of potential therapeutic targets for slowing or even halting the neurodegeneration. For example, enhancing the clearance of abnormal proteins and blocking their transmission, improving the function of mitochondria, and targeting the neuroinflammation are all currently active areas of research.
Alrighty. So moving along here. So Parkinson's disease is driven by a complex interplay of cellular and molecular dysfunctions affecting multiple brain systems. While the most recognized hallmark is degeneration of those dopamine neurons in the substantia nigra, the disease process extends well beyond the dopamine loss. Now, looking at the differentials between men and women with Parkinson's disease, so studies have found that men are diagnosed more frequently than women. This is due to men being studied more often than women. And so the men have higher numbers here. So men also reported that they have more symptoms than women did, but they were not as severe as the female symptoms were. Though men have more symptoms, women are twice as likely to show tremors or have slow movement than men are. So compared to other ethnical backgrounds, studies have shown that Parkinson's disease is most prevalent in Caucasians. As a resident ages, their risk for developing this disease increases. Now, the impact of depression in Parkinson's disease. So let's discuss the common impact of non-motor symptoms in Parkinson's disease, and they are depression and suicide. Now, depression is a common non-motor symptom of Parkinson's disease, impacting the quality of life and potentially worsening motor and cognitive symptoms. Now, up to half of individuals with Parkinson's disease experience depression, which can lead into manifest into sadness, loss of interest, or irritability, and may even develop before Parkinson's disease diagnosis is even given. So in our video, next, we're going to talk about Mr. John. And Mr. John here is going to explain his story with living with Parkinson's disease.
I did not retire when I wanted to. I had anticipated working for at least 2-3 more years because I enjoyed what I did. We used to go to Nevada or Arizona, and I used to do the rock climbing. When you get the shakes, like I'm getting right now, you can't rock climb. It impacts also in your social life because I also belong to a couple of clubs with model railroading. When you have the shakes, you cannot put a kit together. So you end up withdrawing.
It's estimated that anywhere between 20 and 40% of people with Parkinson's disease will experience depression at some point during their illness. So as part of our routine clinical care, every patient with Parkinson's disease completes something called the Geriatric Depression Scale, which is a 15-question yes or no tool that we use to try to help detect depression in Parkinson patients.
And so looking at Mr. John and looking at his experience with living with Parkinson's disease and potentially depression affects up to 50% of individuals with Parkinson's disease. Now, it significantly reduces their quality of life, often more so than those motor symptoms themselves. Depression with the having depression and also with Parkinson's disease, this can worsen and have that cognitive decline, reduce motivation, and impair daily functioning. It may also increase the caregiver's burden and link to higher risk of social isolation and suicide. So despite the prevalence, depression and Parkinson's disease is often underdiagnosed and undertreating, highlighting the need for regular mental health screening and integrated care approaches. So looking at Mr. John here, he discusses his feelings with depression, with also having Parkinson's disease, and how his experiences are unique, but can be consistent with depression.
When Mr. Knight started.
So looking at depression is common within Parkinson's. So depression is common in residents with Parkinson's disease due to its neurochemical changes and chronic disease impact. So residents with Parkinson's disease often experience depression, which is one of the most common non-motor symptoms. Parkinson's disease affects not only movement, but also brain chemicals responsible for mood. Many residents with Parkinson's disease experience emotional and psychological challenges because of changes in their dopamine, serotonin, and in their serotonin levels. Residents may appear as sadness, apathy, low energy, and withdrawal. And so that emotional toll of living with a progressive neurological condition like Parkinson's disease significantly, knowing the condition is chronic and progressive, can lead to feelings of grief, hopelessness, a fear about the future, a loss of independence over time, which can increase the sadness and anxiety in most residents. Residents may feel they are no longer able to do things that once defined them, like working or driving or just managing their household duties. This loss can impact self-esteem and can lead to a withdrawal or depressive thinking. Now, when we talk about depression and it still being common, the physical and cognitive decline experienced in Parkinson's disease can significantly impact a resident's emotional and psychological state. Loss of mobility, speech difficulties, and cognitive impairment can lead to feelings of depression, anxiety, and social isolation, significantly affecting overall quality of life. Now, cognitive impairments, including memory problems and difficulties with attention and executive function, can further exhibit emotional distress. Now, these challenges can make it harder to cope with daily functions or daily tasks, maintain activities, leading to increased anxiety and depression in residents. So, speech difficulties, facial masking, and changes in communication can lead to social isolation and stigma, negatively impacting self esteem and those social relationships. So, now we're going to discuss. John here is going to discuss his impact with suicide. And so the impact of suicide in Parkinson's disease is a serious and often under recognized issue. Now, while not all residents with Parkinson's disease experience suicidal thoughts, the risk of suicide or suicidal ideation is elevated due to the combined burden of neurological changes, depression, anxiety, and declining functions.
While actual suicide is not very common in Parkinson's disease, something called suicidal ideation, or thoughts about, would I be better off if I was no longer here? Would my family be better off if I was no longer here? Am I a burden? How could I do this? We do know that that is relatively common.
You have Parkinson's, there is no cure. They have medications to work on the symptoms, but you can see that you'll always be getting worse. The thoughts are there that, what's the purpose of me continuing on here?
Moving from that point to actual suicide is not very common, luckily, in this population.
I have no desire to do myself in. That's not a concern. Sometimes I think, though, that if I stop taking my medications, what will happen? My world hasn't gotten smaller. It has shrunk. And it's really the lack of interest, or I'm not sure exactly what it is that I have been, or I am withdrawing into my own little world.
So let's now talk about the impacts of suicide with Parkinson's disease. So suicide in residents with Parkinson's disease, especially in long-term care facilities or assisted living settings, is deeply important because it is often an under-discussed issue. Now, up to 50% of people with Parkinson's disease experience depression, and at some point during their lives or at some point during this illness. This is just not a common non-motor symptom. It can also have serious consequences. Depression is a major risk factor for suicidal thoughts and behaviors, and so making early detection and treatment is really critical for improving quality of life and preventing tragic outcomes. The progressive motor and non-motor symptoms in Parkinson's disease, such as immobility, speech difficulties, and cognitive decline, can significantly impact a person's emotional well-being. Over time, these challenges may lead to feelings of hopelessness and worthlessness. And so additionally, the loss of independence and personal dignity, especially in the more advanced stages of this disease, may further contribute to suicidal thoughts and behaviors. Now, let's talk about understanding disease progression with Parkinson's disease. So first, we're going to talk about brain change. So this is the loss in dopamine producing neurons in the substantia nigra, and so a small region in the midbrain, which builds up of misfolded protein clumps called Lewy bodies. And so with these brain changes, the substantia nigra, which again is that small region in that brain, is not producing those dopamine neurons. And so the consequence of that is dopamine is the chemical that lets nerve cells coordinate smooth, purposeful movement. And so as levels fall, movements become slower, stiffer, or shaky. And so this is thought to disrupt cell function and spread to other brain regions over time, leading to both motor and non-motor symptoms. And so a scale that is used is the Hoehn and Yahr scale. There's up into 5 stages of this. And so it is a clinical tool used to describe the progression and severity of Parkinson's disease. It was first introduced in 1967 by Dr. Margaret Hohen and Melvin Yarr. And so this scale primarily evaluates motor functions and postural stability, classifying residents into stages 1 through 5, with increasing numbers indicating a more advanced disease progression. Now, Parkinson's disease is understood through different stages, and so typically categorized in early, mid, and then advanced. And so we're going to review these in our next couple slides. The stage 1 is only one side of the body is affected. Stage 2, symptoms affect both sides of the body. Stage 3, balance and stability becomes affected. Stage 4, symptoms increase, however, are able to stand and walk. And then stage 5, assistance is required for everyday activities. And so we're going to break these down here in our next couple slides. So stage 1 is the early unilateral stage. And so in the first stage of Parkinson's disease, symptoms are mild and typically affect only one side of the body. So these symptoms often include tremors, though they may are barely noticeable. These symptoms usually don't interfere with daily activities or require any specific treatment. Now, stage 2 is going to be that bilateral involvement. So this is considered a moderate form of the disease with symptoms impacting daily activities, but generally not impairing balance. It begins to affect both sides of the body. And so residents in stage 2 may experience increased tremors, stiffness, and changes in facial expressions. Now, the symptoms in stages 1 and 2 are characterized by mild symptoms that are primarily noticeable, like one side of the body. And so those are including tremors. This can look like a tremor is often in the hand, the arm, the leg, and this is a common symptom of this stage. Stiffness and slow movement, rigidity, one side of the body may feel stiff or rigid. Facial expressions. And so residents may notice that one side of their face has less expression and then no functional disability. And so while symptoms are present, they usually don't interfere with a person's ability to perform their daily tasks. Now, when we're talking about some key characteristics of stage 1 and 2, the early stage marks the beginning of Parkinson's, often with subtle one-sided symptoms, though it may not interfere with daily functioning much. And so that unilateral involvement is symptoms appear only on one side of the body, usually a right hand tremor, left side stiffness, those mild motor symptoms, slight tremor at rest, subtle changes in posture, facial expression, or walking pattern, and then minimal functional impairment. Most people are still fully independent and can carry out daily activities without assistance. Now we look at the mid stage. And so these are, so this stage is considered a midpoint of the progression of Parkinson's, and it is characterized by a loss of balance and coordination. Falls becomes more frequent and movements generally slow down. Now, symptoms start getting worse here. These tremors, rigidity, and other movement symptoms affect both sides of the body or midline, such as the neck and the trunk. So walking problems are poor and poor posture may be apparent. The person can live alone, but daily tasks are more difficult and lengthier. And so here, again, falls become more frequent and the movements generally slow down. While residents can still live independently, activities like dressing, eating, and getting out of bed may be more difficult. It is a significant turning point as symptoms begin to impact daily life more noticeably here. Now, looking at stage 3, continuing with that mid stage, it involves mild to moderately disability with symptoms on both sides of the body, and residents are still largely independent in this stage. So considered mid-stage loss of balance, again, such as unsteadiness as the person turns or when he and she is pushed from standing, is a hallmark of this stage. Noticing that those mild to moderate disability symptoms are affecting both sides of that resident's body. Now, functionally, the resident is somehow restricted in his or her daily activities now, but is still physically capable of living an independent life. So disability is mild to moderate at this stage here. Now, looking at some key characteristics of stage 3, looking at those bilateral symptoms. So symptoms now appear on both sides of the body, such as tremors, stiffness, or slowness in both arms and legs. And so one side may still be slightly worse than the other. No impairment of balance, and so postural stability remains normal. Residents do not yet show difficulty with walking or having frequent falls. And then mild to moderate motor symptoms. And so this is the increased beta kinesia, so the slowness in movement. Muscle stiffness and tremors become more apparent, difficulty initiating movement or performing fine motor tasks. And so those are some key characteristics. Now, let's talk about the advanced stage, stages 4 and 5. Now, stage 4 signifies severe disability, but the ability to stand and walk independently, often with the use of assistive devices. So residents may require more assistance with daily tasks and may need live-in care in these advanced stages. And so stage 5 is the most advanced and debilitating stage. Stiffness in legs may make it impossible to stand or walk. So at this stage, residents become bedridden or confined to a wheelchair unless aided. They have to have around-the-clock care is required for all activities in these stages. And so that's stage 4, and definitely stage 5 is those more advanced stages there. And then some key characteristics in stages 4 and 5. So severe disability. So symptoms are severe and disabling, impacting daily activities significantly. Having some assistive devices, it often requires like a wheelchair or a walker. That need for assistance, so may require assistance with doing their day-to-day daily activities like bathing, dressing, even cooking here. Loss of independence, may no longer be able to live independently due to the significant decrease in movement. And then medication adjustments. So Parkinson's medications may need to be adjusted or spread out due to the side effects or diminishing effectiveness. And so those are just some key characteristics of those stages and the different stages between stage 1 and stage 5 with the disease progression there. All right, so now we're going to talk about recognizing non-motor symptoms in Parkinson's disease. So recognizing these non-motor symptoms is crucial because they can significantly affect quality of life, often more than motor symptoms, and may precede diagnosis by years. So we're going to watch a video here where it's going to talk about the non-motor symptoms in Parkinson's.
When most people think of Parkinson's, they think of its movement-related or motor symptoms, which include stiffness, tremor, and a gradual loss of voluntary movement. But there are many other symptoms, some of which begin years before diagnosis that are unrelated to movement. They include reduction in or loss of sense of smell, gastrointestinal issues like constipation, problems sleeping, fatigue, pain, depression, and anxiety, among others. These symptoms can significantly impact a person's quality of life. Thankfully, though, there are many treatments available to help mitigate that impact. It is critical to consult a physician or a movement disorder specialist, as everyone's case is unique. On the research side, these non-motor symptoms give us a critical window into the inner workings of Parkinson's and may help us find ways to better diagnose and treat it. Two of the best examples are loss of sense of smell and gastrointestinal problems. For instance, we know that about 90% of people with Parkinson's have a reduction in or total loss of their sense of smell years or even decades before their diagnosis. Growing evidence suggests this may be related to the earliest stages of Parkinson's, when a likely combination of environmental, genetic, and epigenetic factors trigger changes that lead to neurodegeneration. One of these changes involves a protein called alpha-synuclein, which transforms from a normal version of itself into a toxic one. In Parkinson's, abnormal copies of alpha-synuclein begin to stick together, clogging up cells, and likely interfering with the normal processes that keep cells healthy. The result is cell damage and death, which ultimately is believed to cause Parkinson's symptoms. Research has shown that these proteins can move from cell to cell. From the nose, they travel to the part of the brain that controls sense of smell. Once there, they continue to spread throughout the brain, eventually reaching the cells responsible for controlling voluntary movement. Something similar may be happening in the gut, which is also home to alpha-synuclein. Like the nose, these proteins have a direct route to the brain via one of the longest nerves in the body. The reasons behind these changes in the nose and the gut aren't entirely clear, but growing evidence suggests that exposure to inflammatory factors in the outside world, either through inhaling or ingesting them, may play a key role. These factors may build on other influences, such as genetic mutations, that predispose a person to Parkinson's. If enough of these factors build up, the scale tips and may prompt the changes that make alpha-synuclein toxic and trigger the earliest stages of the disease. Research is ongoing, but over the years, it's become clear that Parkinson's is far more than just a movement disorder. It is a complex disease with symptoms that can vary greatly from person to person, with many different factors that contribute to its onset and progression. The better we can understand all of these different pieces, the better we can find ways to slow or stop it and give people more healthy years. To learn more about the Parkinson's research underway at the Institute,
Okay, so now we're going to talk about how to identify signs and symptoms in residents with Parkinson's disease. Now, clinicians should be able to identify the cardinal motor symptoms like tremors, rigidity, and bradykinesia, and recognize the variability in presentation from person to person. So we're going to identify signs and symptoms in residents with Parkinson's disease. Caregivers and healthcare staff should watch for both motor and non-motor indicators. And so some of those motor symptoms and how to identify is going to be tremors. So often beginning in the hands or fingers, usually at rest. Bradykinesia, slowness of movement that makes daily tasks more difficult. Rigidity, stiff muscles that limit range of motion. Postural instability, poor balance, increased risk of falls, and shuffling gait, small hesitant steps, and reduced arm swing. So those are some motor symptoms of clients who have Parkinson's disease. Now we're going to talk about some non-motor symptoms here, which can look like mood changes. This is looking like depression, anxiety, and apathy. Cognitive impairment, memory loss, slow thinking, maybe some confusion here. Sleep disturbances, insomnia, REM sleep behavior disorder, automatic dysfunction, constipation, urinary incompetence, blood pressure fluctuations, and then speech and swallowing problems. And so soft voice, slurred speech, drooling, or sometimes even choking are some non-motor symptoms. Now, looking at the psychosocial red flags, here looking at social withdrawal. And so reduced engagement with others due to stigma or communication barriers, hopelessness or worthlessness. And so emotional signs linked to suicidal risk. And then the loss of independence, that frustration from needing help with daily activities. Looking at some additional symptoms here, neuropsychiatric symptoms, looking at depression, common and often underdiagnosed. Anxiety may occur independently or with depression. Apathy is that loss in motivation, so not always linked to depression. Cognitive decline, including dysfunction, memory issues, and dementia in later stages, and then hallucinations and delusions, especially in advanced residents with PD or with certain medications. Looking at sleep disorders, a REM sleep disorder is acting out dreams, may appear years before PD is diagnosed. Insomnia, difficulty falling asleep, staying asleep, or waking or feeling underrested. Excessive daytime sleepiness. Excessive daytime sleepiness, also known as hypersomnia, is characterized by irresistible urge to sleep or nap during the day. And then restless leg syndrome, also known as Willis, if I'm saying this right, ecom disease, which is a neurological disorder characterized by irresistible urge to move the legs. And so these are some sleep disorders that relates to Parkinson's disease and some symptoms here. Other non-motor symptoms is fatigue, so not directly tied to physical, but fatigue and Parkinson's disease is described as persistent feelings of mental and or physical exhaustion. Speech and swallowing difficulties, so can overlap with motor symptoms, but speech and swallowing difficulties are common and often progressive non-motor symptoms of Parkinson's disease. Sweating abnormalities, and so sweating are part of the automatic nervous system dysfunction, which affects the body's automatic involuntary processes, and then weight loss or gain, and then often related to medication here. So some additional non-motor symptoms. So now we're going to talk about some tips for supporting residents who have Parkinson's disease. And so supporting your residents with Parkinson's disease, to communicate with patients and clarify, focus on actively listening, using simple language and respecting the other person's perspective. This helps on building rapport. And so staff should also be mindful of nonverbal cues and providing concise explanations, and also key to effective communication. Giving your residents your full attention, both verbally and non-verbally, putting away distractions, making eye contact, and showing that you are engaged allows your residents to fully express their thoughts and feelings before you respond. Encouraging independence with support involves gradually increasing a person's autonomy while providing necessary assistance and guidance. So this is where we can offer choices, which allows them to make decisions about their daily routines, encourage experiments here. We can create a space where it's safe to try new things and learn from mistakes, recognizing their praise and efforts. So acknowledging attempts of independence, even if they are not fully successful, this also helps build confidence. And then step back and observe. This is where you will allow your residents to problem solve on their own before offering your help. So you can also support so to improve mobility and prevent falls, focus on maintaining physical activity, enhancing their strength and balance, using assistive devices when needed, and making their home a safer environment. Consulting with their healthcare professionals like physical therapists is crucial for personalized advice and guidance. So engaged in structured exercise programs that focus on building strength and balance, including yoga or Pilates. Staff can incorporate activities that can promote balance and strength into your residents' daily routine. So that's how you can support them with their mobility and falls. You can also support through adapting daily activities. And so this involves adjusting routines and tasks to better suit one's current circumstances. So whether due to the change in abilities, environments, or personal preferences, this can involve simply simplifying tasks, adjusting schedules, or using assistive tools to maintain that independence. Acknowledging non-motor symptoms. Parkinson's disease also, again, includes non-motor symptoms that can significantly impact a person's quality of life. And so these symptoms can lead, which include cognitive problems, sleep disturbances, insomnia, mood changes, like depression, pain. So these are all ways that you can support your clients who have Parkinson's disease. A big one is fostering that social connection. So fostering social connection involves actively building and nurturing relationships with others, which can lead to and be really beneficial for both their mental and physical well-being. This can be achieved through various methods, including spending quality time with the loved one, engaging in community, even expressing gratitude. And so residents will try to connect with family and friends, or make efforts to simply have meaningful conversations. And then collaborate with their care team. So collaborating with their care team involves open communication, shared decision-making, and coordinated efforts to optimize patient health outcomes. And so this this can include working with various healthcare professionals, such as their primary care, their PCPs, specialists, their nurses, TBS, to ensure that they are getting a holistic and patient-centered approach to care. And so it is important to understand that many of the symptoms overlap with other neurological and psychiatric conditions, such as essential tremor, Lewy body dementia, or even normal aging. It can be easy to misdiagnose residents with Parkinson's disease, but it is not curable, but it is manageable. And so this is how you can support your clients with Parkinson's disease. Parkinson rates are steadily increasing worldwide. Symptoms include tremor, stiffness, and slow movement. Emotional burden affect both patients and caregivers. And early treatment improves quality of life. And family support is essential for care. And so I want to thank you for taking this training today on Parkinson's disease, and hope while taking this training, you have a more clear definition of what Parkinson's disease is and how you can help your clients within sessions.